this type of preventative care requires physicians and medical providers. Joining me now to talk us through the distressing physician shortage and also to promote the diversity that we've been talking about, we want to welcome David Skorton. He is the president and CEO of the Association of American Medical Colleges. Dr. Skorton, thank you for being with us today. And I can tell you firsthand, my wife is a primary care nurse and she is dealing with this every single day. Why such a problem when it comes to a shortage of doctors and medical providers?
Well, first of all, congratulations on these interviews. I've had a chance to watch a bit of it, and very, very important things that you're doing, and I really congratulate you on that.
Thank you.
Well, throughout the healthcare sector, we're running into staff shortages, and this is not something brand new, but it's getting worse. Why? First of all, Steve, except for you and I, the nation is aging, and as the nation ages, we get more people who need more help, more care. Secondarily, the medical workforce, like the rest of the country, is also aging. And as they age, more and more of them will come to retirement age, especially those in my generation, the so-called baby boomers. Thirdly, COVID has really taken its toll on the healthcare workforce. This was a very difficult, previously unknown to us, multi-system lethal disease that really, really took the wind out of the sails of a lot of healthcare workers. And the mental stress on the healthcare workers drove some of them to reduce their hours or even leave the profession. And right now we're facing these shortages in a big way. Now on the physician front specifically, the Association of American Medical Colleges, my organization, has for years been doing a careful science-based projection of physician shortages going over the next decade, whatever year it is. And we have shortages right now of primary care physicians and those in behavioral health and those in rural areas. And we're projecting up to 124,000 physician shortage by roughly 2034. So this is a problem that's been going on, made worse by COVID, worse by the aging of the workforce, and we're facing some real challenges.
And again, a reminder for those of you watching that you can join the conversation on Twitter at The Hill Events. Dr. Skorton, I saw an article that included Cornell University, where you served as president, on how colleges and universities, especially medical schools, are trying to encourage foreign students to come to this country and study here and hopefully stay here. Can you talk about that?
Yeah, I'm so grateful that you brought that up. Having a rational immigration system and doing what we can to support these really wonderful people who come over and end up being as much as a quarter of the workforce is incredibly important, including those that are in the DACA program, the DACA, D-A-C-A program. And I'm hoping, and we really need our political leaders to make sure that that program stays. The last time I looked at the statistics about a year ago, roughly 30,000 healthcare workers, physicians and others, would lose their work authorization if DACA were rescinded. So we need to make sure that we have a rational system of immigration throughout the country, of course, but also in this particular area. We would be in very, very bad shape if it wasn't for the excellent healthcare professionals who come from overseas.
We have been talking about medical technology, the advances in our research and science, and yet despite all of this, the lifespan of Americans is beginning to drop, not extend. So why is that in terms of the physician shortage issue? How does that contribute to our own life expectancy?
Well, in the last 3 years or so, the many deaths, over 1 million deaths from COVID, have contributed to that reduction in life expectancy. Probably the most troubling thing, which you touched on with your last speaker, is the difference in different populations, the health inequities. And we can see a difference in the city I'm talking to you from right now, Washington, D.C., a difference across town in life expectancy of many years. And so that's the first thing to mention, is that the inequities, the differences in life expectancy by a racial or ethnic group, by those who have access to health care, have access to healthy food, have access to safe and humane housing and other determinants of robust health, has been going on a long time. And those inequities were really laid bare by COVID, which, as we know, affected marginalized groups much more than majority groups in the country. So that's a part of what is happening. Furthermore, in other patient groups, in rural areas and in poverty-stricken areas, we're also seeing changes related to just lack of access to health care. And to get health care, we really need two things. You need access. There have to be health care professionals available. And then we need monetary insurance coverage to open the door to those practitioners. So all of these are factors that can limit life expectancy.
I want to come back in a moment to your work at the Association of American Medical Colleges, but you've also been on the front lines of a growing and concerning situation in Uganda regarding Ebola. What can you tell us?
Well, the Ebola virus, which is a lethal virus, there have been outbreaks before. This is an outbreak that started in Uganda of a little different virus than the last outbreak was. And this particular virus, the last time I checked the data, had not come to the United States. And in fact, when I sent a statement out with Dr. Rochelle Walensky, the CDC director, to practitioners around the country, what we were urging practitioners to do was to be aware that since there are no flights from Entebbe to the United States directly, that providers needed to be aware of the requirement to take a careful, extensive travel history to make sure that someone coming from another location in Africa might have also come from Uganda before that location. And so we don't have a problem with the outbreak in the United States right now. We do have assets in the United States that would allow us to deal with it, but it's a very, very serious disease, and we are keeping our eyes on it very carefully.
Thank you for shedding some light on a story that we continue to follow. Let me bring it back to the issue of physicians and the looming shortage. 10 years from now, in 2032, what will the U.S. be facing?
Well, our projection in 2034, basically the same thing you asked, is that we may see a shortage of up to 124,000 physicians. And I want to add one number to that. If today, Steve, those who do not have access to health care, as I've described it, access to a practitioner and insurance coverage, if they had access equivalent to those who are more fortunate, we would be short up to 180,000 additional physicians right now, not counting that projection of up to 124,000 shortage in addition to where we are now by 2034. So this is really serious business.
And without shortcutting the process, once you begin medical school through residency, how many years are we talking about, and how much of an investment in terms of tuition?
So after college is over, it's at least a 7-year requirement. I say at least, because the 4 years of medical school, and depending on the postgraduate training, that can be from 3 years in the case of internal medicine, the beginning of my training, out to more specialties and subspecialties. My own training was 5.5 years after medical school, and some surgical specialties and others are even longer than that, 7 years or more. So it's a major commitment of one's life. And secondly, the cost of higher education in general, medical school in particular, is very, very substantial. In the case of a medical degree, those who choose to go into clinical medicine with that degree, which is most, will have a very, very, very high probability of being able to repay those debts and have a comfortable life. But that's easy for me to say. The idea of looking forward to a $200,000 or $300,000 or $400,000 debt when one is in, say, high school, or when a family with a child in middle school is thinking about contemplating the possibility of a medical career, well, that can be daunting, and I believe it can talk people out of the possibility of even considering a medical career.
So final question in terms of getting the diversity among those would-be doctors. How do you get there?
That's a big question. I wish we had another hour to talk about that, Steve. I know we don't, so I'll make it quick. We really need to do a couple of things. One, we need to work on the populations in which we've had very little success bringing them into the medical workforce. Black men, American Indians, Alaska Natives, first-generation Americans. We need to do specific things on that. We're doing something very assertive through the Association of American Medical Colleges with an action collaborative relating to black men in medicine. Last week, we had a summit sponsored jointly with the National Medical Association. And there's a lot of other work that needs to be done. So that's one thing, is to have young people and their families see the possibility of a medical career way back in the educational lifespan, perhaps as early as middle school or even earlier. Then secondly, we have to make sure that we're doing everything we can to diversify the medical workforce. And Steve, as you well know, throughout higher education, including medical education, the Supreme Court next Monday on the 31st is going to hear arguments about the consideration of race in admissions. And this has been a very important factor to allow us to work toward diversification of the workforce. And I sure hope that we are still allowed to consider race as one factor in medical school admissions.
With the Association of American Medical Colleges, Dr. David Skorton, thank you very much for adding your perspective to this conversation. We appreciate it.
Thank you, Steve. Congratulations on the summit.
And so that brings us to an end of our program. I want to thank you again, and our sponsors as well, Hologic, for their support of this program. And a big thank you to all of you for watching. And for those of you who missed any of the conversation this afternoon, we'll have the video on our website shortly. I'm Steve Scully, contributing here at Hill.com. Hope you enjoyed this program. Have a great rest of your day.